questions for you because I'm preparing something to show you on the last day that I'm with you. So, you see the movie Independence Day?
Yes.
No. Okay, you need to watch it before you don't. Bridesmaids, you see the movie? Oh, you see the movie?
That's one of my husband's favorites.
Right?
Bridesmaids is so good.
You do know that Alabama is #1 in college football and probably going to the playoffs?
No, they're going to lose to OU.
They might. Okay. He is diehard, but I'm very good to it. It's either join him or die. Game of Thrones? Game of Thrones?
Yes.
Okay. So if I refer to these, you know what they are. Okay. The last Harry Potter film?
Yes. Wait, like the last, like the 7th?
Either one, doesn't matter. Both of them. What do you mean the last one that just came out? Not these things. Stranger Things, you've watched that?
Yes. No.
All right, there's enough yeses in there that y'all will get it. Okay. Okay, let's start on, we're going to pick up on page 5. Okay, down the bottom, assessing risk for fatal asthma exacerbations. There are about 5,000 people who die of asthma every year in this country. There's about 100,000 worldwide. Okay? So it's really important to be able to identify those folks. Common risk factors. So it's kind of like in diabetes. It is when people walk in the door, you can already see the risk factors in them. So inner city, if you work in inner city, those people are usually at higher risk. Non-white, non-Caucasian. What else do I have here? Usually they are folks who have, even if they have access to medical care, they do not use it. Or they have a lack of access. Or they don't use emergency services. Other things that I saw is single-parent households, kids are at highest risk. People being able to, a child with asthma sucks the oxygen out of the air for a family. There's lots of attention that's needed and time, and so other children may not be attended to as well. I once saw a family that had 3 asthmatic children. Single mom, high risk. Lower education, lower incomes tend to also be in that category. The other thing I saw is lack of transportation. Also can be a problem. 70% of asthma deaths due to asthma are preventable, and there's a modifiable risk factor. The majority of fatal asthma is referred to as slow onset. So these people usually have unstable airways, and they have not been treated or under control for long periods of time. Okay? Usually there is a very slow progression towards something that leads to a severe asthma exacerbation. So let's see, this says 80 to 85% who die of asthma have a history of progressive symptoms for 12 hours and often for 3 weeks. Autopsy, slow onset, this is becoming more recognizable. They refer to them now as type 1 and type 2 asthma. So this eosinophilic inflammation is becoming more and more recognized as a problem. We talked about some of the biologics in the treatment of asthma, and many of them are going towards that eosinophilic asthma. Airway obstruction, tenacious mucus, and desquamated epithelium due to that inflammation. Changes develop over days to weeks. Most of the people had sufficient time to seek attention before shortness of breath. A lot of times these people have a decreased perception of how bad their airways are. When I was taking care of people with asthma, especially adults, always surprised me And often what I would do is I would paint a picture for the people, parents or the adults, is here's what your life should look like. You shouldn't wheeze. You shouldn't miss work. You shouldn't miss school. Average missing of school for a kid with asthma, due to asthma, 13 days a year. That's just asthma. And often I would get a response from the adults is like, I didn't know that you could have asthma and not wheeze. I had some tell me that I grew up in a family where everybody had asthma, everybody was symptomatic. They get to expect that that's just the way it is. So they don't expect that they should be symptom-free, or that they ought to be able to do their task of daily living without asthma interfering. So they come to accept that as baseline. So when they start to deteriorate, they don't pay attention to it. So it's very important as you, as primary care providers, keep driving that home. If you are in a place where there is an asthma educator, use them. At OU, the PEDS group had a big asthma education group. They had a person who went into the hospital. That is really one of the best times for an asthma educator to show up and talk to parents. The other is that I always try to get them into the clinic within 1 week of an asthma exacerbation. After that, they kind of go back to normal, and the return rate is about 25%. So really getting their attention is important in helping them to know this is what is possible. Because you can have, even though we talk about it being a reversible airway, over time it can develop irreversible components. So it's important to get them under control before all of that happens. On the next page, recent history of poorly controlled asthma. So we kind of alluded to that. 70% of patients who had a near-fatal asthma attack reported a prior history of intubation or a needing to be resuscitated. Study of patients discharged after mechanical ventilation for a near-fatal asthma. Mortality rates, 10% at 1 year, 14% at 3 years, 23% at 6 years. You have to identify these people and get them into a program that will work for them. Other risk factors, allergic asthma, so high allergy component to it. Food allergies, it just tells you they're more atopic. Their immune response is more strong, more exaggerated. Aspirin and non-steroidal induced asthma. 10% of asthmatics are aspirin sensitive. Sports and exercise. Basketball and track, most common sports associated with fatal asthma, boys 10 to 14. In my experience, those were the hardest kids to get to take steroids. And I told you in asthma, what I found, which shocked me, was most of the time the parents just gave the treatment over to the kids. I was just shocked how many times. The youngest I ever ran into was a 7-year-old. Whose mother, single parent, she had a second child with special needs. She said, all my energy goes to that child, he has to take care of it. She could not answer me one question about how he took care of his asthma. And he wouldn't talk to me, he was scared to death of me. Like, how many times you take your inhaler? No response. So, getting on top of those kids, and at least for exercise induced, and for just taking their medicines, really important. A lot of them will overuse their albuterol and they won't use their corticosteroid at all. Illicit drug users. So anything that changes your mental status or your mental alertness usually is going to interfere with other parts of your life, and this one is no different. People who smoke. Marijuana smoking and cigarette smoking. Very common. Precipitants, and they interfere with the drugs. Respiratory viruses, very common. I don't know why menstrual periods do that. It's blamed for everything, so I can't tell you the mechanism behind it. The longer they've had asthma, the more non-inherent the other comorbid illnesses that exist, the delay in their care. So all of those go into it. So a lot of this should be taken care of by primary care, but it also are things that you need to ask as you are discharging them out the door. A lot of things can be said because you will have their attention. So assessing for fatal asthma is then just summarized in the charts at the bottom of that page. If you look at the very last box on the left, it says, if major risk factors are present, assume high-risk fatal asthma. If only minor factors, then possible high risk. Okay. Okay, so let's talk about treatment of acute asthma. So a lot of this you'll be familiar with. We talked about it in asthma. I would highly advise you to get out those handouts that I gave you in Pulm, especially with the drugs, and keep them kind of beside you that you can go back and refer to when you are studying this material. This is very common. Asthma is one of the most common diseases of childhood, chronic diseases of childhood. You're in PEDS, you will see it a lot. You work in an ER, you will see it a lot. When I was in the ER, there wasn't a night that went by that we didn't have somebody with asthma come in. Rapid reversal of airflow, airflow limitations, so we're going to use those bronchodilators, and we're going to very early use steroids. This on top, if they are using steroids, we're going to put steroids on top of that. So even if they're taking an inhaled steroid, we're going to put PO or IV on top of that. And we want to correct their hypercapnia or hypoxemia. Okay, so oxygen. Almost all these folks are going to get oxygen. The goal, though, is maybe a little bit different than what you expect. We want to maintain their pulse ox above 92 or greater, or above 95% for pregnant women. It's preferable to keep it in that range than to going to 100% because they will, you can stop them breathing. Because that CO2 is a very powerful respiratory stimulant and driver. Go back to, let me make a comment on, because I had to go through it fast, on page 5, under hypercapnia. That third, fourth, and fifth bullets. So I just go back through that. So early on, as they're having trouble breathing, their respiratory rate's going to go up because their CO2 will rise. That will drive their respiratory rate. They'll pick up their respiratory rate. If you are breathing 30 times a minute, then your CO2 should be lower. Okay? As they progressively, as the asthma gets worse, then what will happen is you may hit them at a point where their CO2 looks normal. If the CO2 looks normal and they don't, then the number is telling you that things are getting worse. So that's what I meant by that normocapnia, is telling you the respiratory drive and the brain can no longer get the lungs to do what it needs to do. Then if they come in, if it's progressively worse, the worst is that they then become hypercapnic. They just can't breathe off that CO2. And no matter how high it goes, the brain cannot override it. Okay? All right. So back to page 7. Okay, inhaled beta-agonists. So the Albuterol or the beta-2 agonists are going to be your standard of choice. It's got to be inhaled. I'm saying that because in the past there were oral agents. There still are, but we don't use those. We want it inhaled. So there is standard dosing, and then there or nebulization, or using a meter dose inhaler. So depending on how much the person can cooperate with you and the severity of the respiratory distress, a meter dose inhaler or a nebulizer are your choices. Meter dose inhaler is just as effective as a nebulizer if done correctly. When you use a meter dose inhaler, you're always going to do it with a spacer device. If you use a nebulizer, this is a common one that they would use, is the Jet Nebulizer. Just to show you what that would look like. There's a person using it. So we're going to take the drug, which is in an amp, you'll put it in the drug well or the medication well that you see up there on the upper left. And it's going to blow through either oxygen or room air, and it's going to put it into a form that most of the size of the drug is going to be in an inhaled size. Remember we talked about an inhaler, how when the drug comes out, it comes out in all different sizes, and the big heavy size drops out. That's usually what settles in the mouth and causes trouble sometimes. And when we use a spacer device, that allows that to fall out in the spacer, and then we can breathe in the size particles that will get down into the lungs. Well, the nebulizer does that very well. We use bigger doses, nebulized doses, than metered dose inhaler doses. Why is that? Look at the nebulizer dose, 2.5 to 5. What's in the inhaler dose? The MDIs, 90 micrograms. So nebulizers, while they are very inefficient in terms of delivery of a drug, they are sometimes the most efficient for a patient. So if a person cannot cooperate with you, if they cannot bring enough updraft, so you have to have enough air that you can generate, pressure, to get the drug down into the lungs, then a metered dose inhaler may not work as well. And so a nebulizer sometimes. Nebulizers take more time though. So a metered dose inhaler is 5 seconds. Nebulizers are 10 to 15 minutes. So standard nebulization dosing of albuterol, you must know this dose. Most ERs are going to use this. 2.5 to 5 by Jet, handheld, updraft is another, all these are words. These are every 20 minutes for the first hour. Most people with a mild to moderate are going to respond, and their peak expiratory flow rate is going to come up. It'll come up into the 70 to 80 range. We're going to call that good. We're going to watch them, and then after 4 hours or so, if they're still maintaining, we'll send them home. So meter dose inhalers, remember the spacer devices, we've probably given some of those out at Good Shepherd. And the spacer devices, remember, are volume. So the volume depends on the size of the person. So this is an adult size. Remember, we have masks for the little kids that are attached to those spacer devices. The canister goes in one end, and then there's a mouthpiece on the other that allows them to breathe the drug in a captured space. Okay. So there, know that dose. It's 4 to 8 puffs every 20 minutes for the first hour. You can't put people on a continuous nebulizers. Those are usually, there are machines that do that. That will deliver 10 to 15 milligrams of the drug every hour. Usually they're on a respirator, and this would be more ICU, or they're on some type of assisted device for breathing. Those devices then will fit into that machine. Usually your respiratory therapists are going to be doing that, but that is another form of delivery. Okay. Questions about those? That should all sound familiar, right? Next page would be inhaled anticholinergics. So you'll see in some of your emergency rooms, they'll just use both of them right off the bat. So an inhaled ipratropium can be added. It comes in a liquid form. You see it up there, the ipratropium. It can be added to a nebulizer, given in conjunction with the albuterol, or it can be added later if they are not responding as you expect them to respond. So they are never used in place of for acute asthma. They are additive only, and probably best used when the person is not responding fully to the albuterol as expected. However, some people use them right off the bat together. So 50 micrograms every 20 minutes for 3 doses. It shows you there for where it has added value is in those severe exacerbations. There is a product, Duoneb, there in the bottom right-hand corner. That is a combination product for nebulization that contains both. Or you can use them separately and mix them in the same well. So you can use ipratropium and albuterol together. Questions about that? Okay, steroids, when to use those. So why do we use steroids in acute asthma attack? What does it do that helps?
Decrease inflammation.
Okay, it's inflammation, but what else does it do? What are the problems with overusing a beta-2 agonist inhaler? Loses effect. What do we call that? Continuation is called tachyphylaxis. Yeah, is the word. Okay, so, and what does that do to?
Receptors.
Decrease it and downregulates receptors. Okay, you are overloading those receptors. Remember, they are those receptors once they attach to a ligand, they're internalized. They release that ligand, and then they get put back up to the cell membrane. It takes time. So what steroids do is they increase that sensitivity. They restore that sensitivity. They make it so that there are more receptors available and can interact with the beta-agonists. Beta-agonists will be more effective if you're using the steroid. The bad thing is that there's a delay. It takes about 6 to 12 hours. So the recommendation is to use them early. You can use them in any way that you see best. Oral prednisone, very well absorbed, almost 100% bioavailability. So if they can take oral, you can use that, or you can use an IV. We usually don't use IM, but IV can certainly be used. You see about 2/3 of the way down the page, the dose that's used is mostly based on just experience and what people have done. So there's not really studies that are going to tell you these are the right dose. So we use methylprednisolone. 60 to 80 every 6 to 12 hours is a higher dose, or 40 to 60 every 12 to 24 hours is a lower dose, either one. Use IV until they can take PO and transition into that. Okay, so most people that are going to come in to an ER or admitted to the hospital are going to have a severe enough attack that you should think about what are you going to do with the steroids. So as soon as they can resume their inhaled corticosteroid, you would get them back on that. You can use oral on top of that, and you would for whatever length of time. 10 to 14 days is recommended if you've got a more severe attack. You could use shorter if you thought that they were, let's say they responded well, their peak expiratory flow rates came back up to normal pretty quickly, maybe their post-viral syndrome, you can put them on a shorter period of time. But that 10 to 14 days is safe. You don't have to taper it. As long as you're under 21 days, you can give it to them, take them off. What's the dose for kids for steroids? You wrote a prescription on this. It's 1 to 2 milligrams per kilo per day. For adults, we usually use in that 40 to 60 range. Memorize that dose. I'm sure if you go on to peds, anybody going on to peds right away? Know your doses. Know your doses. Okay. All right. So the key to really getting them out of a bad attack is that steroids. Okay. Max sulfate. Does that surprise you? So if we've got where else do we use mag sulfate? Okay, for heart arrhythmias, where else do we use it?
Pregnancy?
Okay, if we're replacing, we usually, we
To stop
can do that if they're low. Okay, okay, preeclampsia. And what do we do that for? Seizures. And what's the other thing? You're 28 weeks and you're going into labor.
To stop the contractions.
Stop contractions. Smooth muscle relaxation. Magnesium is a calcium antagonist. Okay? So it will relax smooth muscle. So a lot of people are moving towards, if you have a severe attack and it's not responding like you want it to, then they're giving 2 grams of magnesium sulfate. Some people do it earlier as later. There's no studies to say this is the perfect time, this is the best patient. So mag sulfate. What is the one thing you're worried about with magnesium? What will be the one thing that'll get you into trouble with it? What? Renal. Kidneys. Most of the time, young adults, kids, it's not going to be a problem. But magnesium does have significant toxicity if you cannot eliminate it. Mechanical ventilation, when to ventilate someone. If you look at that second bullet, slowing of respiratory rate, that should not happen. That is a failure. That's organ failure. Depressed mental status, so change in mental status, can't get enough oxygen in them. Inability to maintain a respiratory effort, they wear out. You can see the work of breathing is very high in these situations. Worsening hypercapnia. Associated respiratory acidosis is a big sign when you get that much. Inability to maintain oxygen saturation above 95% despite a high flow of supplemental oxygen. So know those. The rest of it I'm not going to test you on. It's more telling you different tidal volumes. Decision to hospitalize. So there, we're going to go to continued need for the ability to observe and also the ability for self-care. So if you don't feel like somebody can go home and take care of themselves in the next 24 hours that will be productive for them, then keeping them in the hospital is reasonable. So if you look at the bullets, those square bullets, so if people have not had substantial improvement after 4 to 6 hours, so they're going to be in the emergency room usually for a period of time. Severe symptoms that preclude self-care. If their peak expiratory flow rate will not come above 50%, that's worrisome. You'd really like to have them at about the 70% range before they go home. So look on the next page, 40 to 70% are predicted if they've got good asthma self-care, supportive home environment, and discharge. So a lot of it will go on clinical indicators. A lot of it will go with your experience. People who are unsafe for discharge would be new onset. Multiple prior hospitalizations, ER visits for asthma. If they were on oral steroids at the time they deteriorate, that's a bad sign. So people above 70% or normal usually can go home and take care of themselves. Questions about those? So once we've done that 1 hour of bronchodilators, we're usually going to wait an hour, and we're going to see where their peak expiratory flow rate is. And if they still are having trouble, we'll dose them again. But we'll just do it once. We're not going to go through that every 20 minutes again. Got the steroids, so we're going to be doing that about every hour. And hopefully by 4-hour mark, they're improving enough that we can send them home. If not, then the decision is to keep them a little bit longer or to hospitalize. Meds on discharge. So probably the bigger decision you'll have to make is is to make sure they've got enough medicines, that they've got follow-up. The bigger decision is what are you going to do with the steroids? If they have quit their inhaled steroids, or they are not using them or haven't used them, you're going to restart that. And then you're going to make a decision on oral steroid or not. If they've been hospitalized, I would suggest to you, then they really do need a continuation of that. Because it takes that airway time to get back to whatever their normal is. They really need patient education. You've got an in-house asthma educator, you need to have that person interact with the family. If you've got asthma education that you know of, it needs to be, if you can send a referral in your area, send it. If not, they really need that PCP follow-up shortly thereafter. Make sure they have a spacer device if they're a kid. If they're an adult, they can't demonstrate the ability to use it appropriately, put a spacer device on. Patient education, what do they need to cover? This probably is going to be done on more on an outpatient basis, but they need to know what is asthma. I had all kinds of models I showed them. They need to understand what the treatment is, how to use things. So how do you put the spacer device on? How do you put the canister? How do you use a canister? How do you know when it's empty? A lot of them now have a dial that'll tell you how many actuations are left. They need to really know about trigger control. So we've already talked about that triggers are usually one of the causes of exacerbations, and the removal from those triggers is very important in treatment, especially when we're managing a home exacerbation. So going back through, the back of the sheet that I gave you has a big list of them, and I didn't copy that off for you. But in the Pulm asthma, I did give you more on trigger control. It is really important. I can't tell you how much difference it makes. As an asthma educator, it's the big thing I go after. Usually I can keep people on the same amount of drug and get so much better response if I just take care of the triggers. I have called a lot of landlords, and it's like, you gotta get this cockroach. I used to threaten them, this is before y'all's time, but there was a guy on one of the channels, and he would go after any kind of injustice, so I just like, I'll call so-and-so a channel, whatever. So, changing filters, getting rid of cockroaches, having big talks with families about don't smoke around these kids, don't smoke in the car with them, don't smoke in the house with them, don't let your kids sleep on upholstered furniture, don't, if they're sleeping on the floor and it's carpeted, you need to have another arrangement. Okay? Those are big. A fan that's constantly blowing dust around. Any of you sleep under a fan and you wake up more congested? Yes. Oh, yes. Strong dust in your face all night. Okay. So things they need to know how to use that peak expiratory flow meter. If you've given them one, they need to know this is your control medicine, this is your rescue medicine. They usually know their rescue medicine because they can tell it works. They need to have a written action plan. So those goals of therapy, and you can tell them these things. Here's what you should expect. You should expect that your child will sleep through the night. You should expect that they don't miss school because of asthma. You should expect that you don't miss work because of asthma. You should expect that if they want to play in sports, they can do that. Or they can take part in PE and they don't have to stay in or recess. You should tell them about the short-acting bronchodilator. We expect that you should only use this about once a week, if at all. We should expect that you don't have exacerbations. You don't have to go to the ER. You don't have to go to the doctor. We don't want you to be hospitalized. And that, except for the severest of all, we expect that you can live a normal life. Some of them will not know what that is. Next page, on page 11, then I'll come back to the action plans. So oral glucose, this just goes over doses that we've already talked about, timelines. IM may be may be useful in a few situations. If you have somebody going out the door that you think is no way going to ever adhere to anything you said, you could give them an IM injection of a steroid. The problem with is that you don't know how long it lasts, and it's variable absorption. So it's not anything to ever think about unless you just absolutely have to do it. I would say in all the times I have been, we never did it in the practice I was in. Inhaled glucocorticoids, again, making sure it's part of their discharge plan. Okay. Let's go over the action plan. They all have this kind of setup. They may lay it out a little bit differently. This one is a little bit more detailed. But you'll see at the top they have their contact information, so they know who to call. And then we divide it into those zones. Remember the zones that the green is you're at your peak expiratory flow rate, your personal best, you're at 80% or above. Yellow is you are 50 to 80%. Red is below 50%. So we use that stoplight analogy. Okay, doing well. So over at the side it tells them kind of here's what doing well is. You're not coughing, wheezing, no chest tightness, you're sleeping through the night, you can do your activities. All those are those goals we told them about. If they use a peak flow, they know what their numbers should be. For kids, this would adjust as they get older. For adults, as they get older, it would also adjust every 5 years. It outlines their medicine, how much to take it, when to take it. And at the bottom, it shows them for exercise, if you're going to tell them or advise them to do that. So that's what they ought to be doing all the time. Now, if asthma's getting worse, so it tells them, here's what worse looks like: coughing, wheezing, chest tightness, shortness of breath, waking up at night. I can do some but not all of my activities. I can play, but I can't play as hard as I want to. I get in trouble when I go out when it's cold at recess. Peak flow gives them the numbers, tells them what that is. So if you've got people who have frequent exacerbations, they ought to be using a peak flow meter, because they can start to predict and to see. So now this is where it gives them an action. What do you do if your peak expiratory flow is in that yellow zone? They're going to use their short-acting bronchodilator. They're going to use their Albuterol. And it gives them 2 to 4 puffs every 20 minutes for up to an hour, or they can nebulize. Okay, so same thing we would do in the ER. If symptoms and peak flow return to green zone, then keep doing what you've been doing. Go back to your usual green treatment. Or if your symptoms do not return after 1 hour, then it tells them use that short-acting bronchodilator again. And for people who have recurrent asthma, need a recurrent steroids, or have frequent exacerbations, you can give them steroids to keep at home and start. You usually are going to do this with people you know and you've educated and they demonstrate an understanding, because you don't want them just indiscriminately taking those steroids whenever. So you're going to tell them what to take and for how long. And call the doctor. Here, you want to know they've started a steroid. Let's say they're in the red zone. Again, it tells them what that looks like, tells them what the peak flow looks like, tells them to take that short-acting and start a steroid. Usually we'll tell them go and seek medical help. It has been shown that the sooner you can get that in, especially that steroid, the better usually they'll fare. Okay. Danger signs are there listed at the bottom. Okay, everybody should have this. If you're a primary care provider, when they come in, they should say, tell me about your action plan. Did you bring your action plan? I'm bringing up your action plan. Let's review it. All right, the next page is reference only on page 12. Page 13 and 14 is a summary of what we just talked about. Page 15 is a flow diagram of emergency treatment. And did I put the home in there? Okay. All right. Questions about the asthma action plan? Okay. All right. Page 16. So the goals of home management. So a lot of people with mild and that are in that yellow zone, they can be managed at home. That would be a good thing. So we want to relieve symptoms and we want to prevent deterioration. You would only do this with people who had an action plan, had the medications available, you've trained them, and you have confidence that they can execute it. So they're going to use a short-acting beta-agonist. That's what we want them to do. Again, 2 to 8 from a meter dose inhaler, just like we would do in the emergency room. Or they can do a nebulized treatment. Either way, whichever one they have, or if they prefer one over the other, if they have both. If after that first hour they have improved, then we're going to just tell them to continue with their regular care. If they need beyond that hour, they ought to contact a doctor. They ought to have, or a nurse, or their asthma educator, and for further instructions. Okay, what do I do? If they have marked decrease in their ability to speak, their use of accessory muscles, peak flow drops below 50, then that you would want them to go to the emergency room. So these are things you could rehearse with them. Now, I want you to be aware that there are these products over the counter, so that they can get Racemic Epinephrine over the counter. There are 2 products. There is Asthmanephrine and S2 inhalant. They are Racemic Epi. They can buy it without you knowing about it. They can buy it without a prescription. They can get it at Walmart. They can buy it at eBay, Amazon. The FDA has issued lots of warnings about this because people tend to can have severe effects. The other thing is it delays them getting to a doctor. Probably about the time you were born, there was a and I can't think of her name, very famous model. And she used one of these products to the point where she died at home because it delays them getting anywhere. So I would warn my patients, do not use these. I would be on more high alert for people who did not have sufficient funds, non-adherent with other medicines, people that don't quite believe you know everything you're supposed to about it. Maybe other people in the family use it. Bring these up, advise them, do not use them. Make sure they have enough medicine to always treat themselves. Again, these drugs are expensive, so you always have to keep that in mind, is that people may not be able to afford their inhalers. So that's Asthmanephrine. You can see it's very much like a very small nebulizer. It's an atomizer. It comes in these packets that they put into the machine and then turn it on and use it to administer the drug. Here's the S2 inhalant and what it looks like. Okay. beta-2 specific. That's the problem with them. They're also alpha-1 and beta-1. So people who have underlying heart disease can be harmed by these. So advise them against using non-selective epinephrine products. Okay. All right, so what do you do based on their response? Well, a good response would be their peak expiratory flow rate comes up to goal. Their symptoms go down. If they're at home, the big thing is get away from the trigger. Here you might consider a short-acting, 3 to 5 days of an oral glucocorticoid. If you go down to incomplete response, these are continued symptoms or their peak expiratory flow rate will not come up to normal. So those people, a steroid again can be very helpful. Single most effective strategy for ER visits and hospitalizations, avoiding them, is getting that steroid in early. Remove the offending stimulus. Continued observation. And giving them a time where if you haven't improved by then, you need to seek medical help. Need for urgent attention would be a peak expiratory flow rate less than 50% and not responding to their beta-agonist. That that next to last line, under no circumstance should they drive themselves to emergency care. I told you in asthma, 2 students that I have seen die due to that very thing. One was over Thanksgiving. Both of them were in Austin. No, there was one here, sorry. One was here, one was in Austin. Girl in Austin, she had stayed in Austin over the Thanksgiving weekend. Her family had gone out of town. Very same thing. She got into trouble, and she got in the car, tried to drive herself to the hospital, and died along the way. Okay. Same thing happened to the girl here in Oklahoma. It's that underappreciation for how bad their airways are. Both of them tried to get themselves to the hospital. So always warn them, never, here would be what you would advise them to do. Take their beta-agonists, call for help. If they've got a steroid at home, use it. And while they're waiting for help or while they're waiting to get to the emergency room, continue to use that beta-agonist as you have instructed them. Okay? Rehearse that with people. Okay, so there's the home treatment on the next page. Questions about asthma. So it's not learning any new drugs. It's learning doses, sequencing, and the big thing is your observation of and your surveillance of their breathing. All right, so page 19 for COPD exacerbations. So a COPD exacerbation is an acute event characterized by a worsening of patients' respiratory symptoms that's beyond day-to-day variation and leads to a change in medicine. So every year there is a group called the GOLD Initiative, and they put out guidelines every year. So the last ones just came out for 2019, came out right before Thanksgiving. So I have posted the pocket version on D2L. I would highly recommend that you download that and keep that with you when you go on to medicine or whenever you're dealing with patients hospitalized or on an outpatient basis. You'll see a lot of COPD. So I was looking at the pocket version. So the first pocket version I ever downloaded, I don't know, 10 years ago was about 8 pages. I think this one's about 45. So you can go on, you can download the big one if you want. Because they don't give you all the details in the pocket version, but it's a very good and easy thing to look at for just quick reference. The one thing the GOLD Initiative has done is they are trying to get much more literature-based and evidence-based for what is done. So up until I'd say 10 years ago, there just wasn't a lot of organized approach to the treatment of COPD. There is nothing you can do to cure it. So it was kind of everybody's local and experience approach with managing just symptoms. So now we have much more preventive strategies. We have much more logical flow of how you use drugs and when you add them. But the thing that kills people with COPD fastest and most are exacerbations. So they're very important to pay attention to and to try to prevent at all costs, because that's where the majority of them will die. Most of the time, these exacerbations are due to a respiratory illness. Okay? It can be viral or bacterial. A lot of time they're bacterial. So now we have, and there has always been an interest in prophylactic antibiotics. And so we're a little bit better now in knowing when to use those. So we'll talk about that. We now have more immunizations that we can use to prevent pneumonias. So what are those? Pneumovax, Prevnar, influenza. Every year, influenza. Pneumovax and Prevnar their schedule depends on the age of the person. We'll go over those as well. The biggest thing is quit smoking. Number one, quit smoking. The only thing that has been shown to prolong life with COPD is oxygen for those that qualify or meet requirements. So COPD exacerbations, mild, are treated with a bronchodilator only. Moderate would be a bronchodilator plus antibiotics as oral steroids. And severe would be those that require some type of hospitalization or emergency treatment. The big problem, or one of the dilemmas in COPD also has been, is where do steroids fit? So in the past, I would say when I was at your point in education, lots of people got put on steroids, and they stayed on them for the rest of their life. So they had all the steroid complications, and a lot of them died from those instead of the COPD. Then when the inhaled came out, we kind of treated it like we did asthma. We just put everybody on inhaled, but we found out it didn't really change anything. It didn't change outcome, didn't change their PFTs, didn't change their going to the hospital. So there's much better guidelines about when to use inhaled and when to use oral agents. So you'll see that as we go through. The big thing, most important, we talked about these in COPD last time, I believe, are cardinal symptoms. The presence of cardinal symptoms will guide whether you admit the person or whether you give them antibiotics. So cough increases in frequency and severity. Sputum production increases in volume or changes in character. So what would that mean? Color change, more tenacious. So what colors would be worrisome? Green, red, okay. Maybe a very dark golden yellow. So, and the other is dyspnea increases. That's a big one. So pathogens, you must know these. So Haemophilus influenza, Encatarrhalis, and strep pneumonia. Those are your most common. The one you worry about the most is Pseudomonas. But it only occurs in people who have a risk for it. So you need to know those. So let's look at the risk factors. Frequent exacerbations requiring antibiotics. Ding, 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 this ought to ring true. We've talked about it in multiple infectious diseases. The more you treat somebody with antibiotics, what happens? Resistance goes up, drugs can't be used anymore. So this should be something you go, oh yeah, I know this. If they've had a hospitalization, surprise, we've seen this one before, right? If you've been in the hospital, you've been exposed to weird bugs and you come out and you're either resistant or you're more susceptible to the bugs that are more dangerous. Severe airway, airflow limitations, so an FEV1 less than 50%. or they had Pseudomonas before. Okay, so know those risk factors. Okay, so use of antibiotics can improve clinical outcomes, and here's the 6 things they do, so you should be able to recognize those. Because in your mind, you're going to go, there's evidence that what I'm doing is right. So it decreases mortality, decreases in the duration of having to be intubated, duration of hospitalization, yay, less bugs, less cost. Clinical cure increases, great. The time to the next exacerbation, so instead of having one every 4 months, you go out to 6 to 8, great, your risk of dying goes down. Resolution of symptoms, yay, I feel better. I don't feel like I'm going to die. Okay. So the GOLD guidelines, and most people go with this, recommend that those who have all 3 should be on antibiotics. If they have 2, then 1 has to be increase in purulent sputum, or the patient has to be intubated. Okay. Important to know. So our goals is we want to minimize the impact of the current exacerbation. We want to prevent them from having any more, so that we can keep them alive. So home management. Home management is important because most of COPD exacerbations can be treated at home. The mainstay is a bronchodilator. Okay, so a lot of this is similar to what we see in asthma. Here, it's always Albuterol, it's always a Beta-2 agonist because onset is quicker. Ipratropium can be used or not used. It may help, may not help. Doesn't hurt usually, but it may not add anything. Some people have at home dual albuterol, ipratropium inhalers. You can use those. If that's what they have at home, you can do that. Steroids have a small but maybe beneficial effect. So prednisone 40 milligrams for 5 days is the recommended dose if you're going to use them at home. Antibiotics. Most of the time people will not use them if it's mild and it is responsive to the bronchodilator and the steroid. If they have to be on an antibiotic and you're going to do it at home, look on the next, on page 22. Then it shows you the different antibiotics. Antibiotics are going to hinge on whether or not you think if you're dealing with Pseudomonas, you're going to admit them. So here they're going to look at complicated versus uncomplicated. So you see under the uncomplicated, you got macrolides. Most of the time azithromycin is used. A 2nd or 3rd generation cephalosporin, doxycycline, or triamcinolone. Fairly broad antibiotics, good coverage with gram-negative and gram-positive. The other is antiviral therapy. If you think that influenza and you're in a peak time of influenza like now, then use an antiviral. The one that's recommended is Tamiflu. It can decrease severity and duration of symptoms by a day or 2. And for these folks, that is well worth the cost and the use of the drug. Okay? So at home, bronchodilators, steroids, plus or minus antibiotics, depends on the severity, and an antiviral. Okay. Let's look at if you have to put them in the hospital. Same thing as we're going to use bronchodilators, mainstay of therapy. Again, a Beta-2 agonist plus or minus an ipratropium. Here, steroids are shown to be a much more benefit. They shorten recovery time. That's big. They improve FEV1. They improve arterial oxygen levels. The second is really important. They reduce the risk of early relapse. Early relapse usually will take place in about the first 2 weeks. They decrease treatment failure, decrease length of stay. know why we use steroids. Very different than what we do with asthma. And there it's, again, it's methylprednisolone, it's usually given IV. The range is about the same we saw in asthma, 60 to 125 over 6 to 12 hours. Antibiotics. These folks are going to usually get antibiotics. So again, who to give antibiotics to? Those who have the 3 cardinal symptoms or 2 of the symptoms as long as one is sputum purulence. Or they require mechanical ventilation. Same thing we saw for outpatient. Choice of antibiotic is based on Pseudomonas risk factors. If you look on page 23, you'll see that. You'll see right there in the middle, risk factors for Pseudomonas. Yes, then you're going to use fluoroquinolone, a third or fourth generation cephalosporin, or an anti-pseudomonal penicillin like piperacillin tazobactam. If they don't have risk factors, again, you've got fluoroquinolones and third generation cephalosporins. So the only thing difference with the Pseudomonas is that you've got anti-pseudomonal penicillins, and you're going to go with more gram-negative coverage. So your fourth generation cephalosporins show up there. Other therapies are going to be oxygen. So look at the target, 88 to 92, kind of on the low side, right? Again, you got to be really careful with oxygen in COPDers because they are very dependent on an elevated CO2 level for respiratory drive. They become accustomed to it. And if you knock it out, they will stop breathing. Ventilatory support if needed. Others would be fluid balance. Maybe they've gone into failure and they've gotten, because remember they're at risk for right-sided failure. Nutritional aspects, again, COPDers put a lot of energy into breathing, so they can become very nutritionally deplete. Do they smoke? Other comorbidities need to be addressed to help them stay healthy, or as healthy as they can. All right, so that's inpatient treatment, just big pieces. Questions about that? Okay. Prevention of exacerbations. This is an important one. You'll see this one a lot. And you should employ it if you're using or taking care of people with COPD. So prophylactic antibiotics, still controversial. For most people, there is no evidence that prophylaxis helps. For people, you should think about it, frequent exacerbations. And that's for people who are optimized. So if you've done everything you can to optimize your bronchodilators and steroids if needed, your people who have had frequent exacerbations also will be on usually an inhaled steroid. So that category 3 or stage 3 were people who go back and look at your COPD treatment just to refresh your brain. So here we use azithromycin. So you got a couple of different options. You can use low dose every day, or you can use it every other day or 3 days a week. Here's the expected outcome. Increased time between exacerbations. Yay. Reduced frequency. Yay. Okay. If they have an exacerbation, you're not going to use an active, just as a reminder. So if they're coming in the hospital, it'd be one thing to ask. Have you had any antibiotic use in the last 6 months? They tell you, yes, I take azithromycin, and then you're going to move to one of the other classes. And then the immunizations you've got down, flu every year. These people are at such high risk. This is what they die of. It's usually related to lung or heart. Pneumococcal, remember, if they had it before they were 65, and if they are COPD or before the age of 65, you should administer a pneumovax. If they're after 65, regardless of whether they had it before they were 65 or not, you re-immunize them. The Prevnar is for age 50 and above. Remember, we never give them together. You can give pneumovax and flu together. You never give Pneumovax and Prevnar together. We'd like them, Prevnar to be first if you can do that, and separate it by year, then give them Pneumovax. Sound familiar? It should. I mean, okay, so then on the very last is you have just a very quick rundown. I gave you one for asthma and one for COPD. Dave does a really good job of just outlining those. To me, it helps to organize it and for you to run down and go, yep, good. Questions about those? Great. Thank you. I appreciate you.